Great.
All right. So, first of all, I want to thank everybody for showing up. I think you will find this will be enormously useful to you. Dr. Volpicelli is a great friend of our community and just a wonderful person trying to help people get better. So, we're really fortunate to have him here. Um, Joe, it's been 30 years now,
30
almost
years, yes.
exactly, since naltrexone was approved by the FDA. Tell me, how did you feel on that day?
Well, so I was, so first off, let me say something. There is the day that the publications came out in 1992, and that was a day that I knew the publications were going to come out. The news was embargoed. It was actually a Friday the 13th that the news came out. So that was really exciting. And there was some media coverage of that. So people were kind of excited about getting the publication from the study we did at Penn and a study we did at Yale. And amazingly enough, when I was watching Saturday Night Live that weekend, that Saturday, they mentioned the study. I think there was a joke on Weekend Update or whatever, and they mentioned about naltrexone.
Wow.
So I was really excited that this was going to be something brand new and really hot, and people were going to get all excited about it. And then we were able to convince DuPont, the pharmaceutical company, to go ahead and get the FDA approval. And we licensed our data and made it available to the FDA. And it took the FDA 2 years to approve naltrexone. But the approval was actually on December 30th. So it came in under the wire. No one even knew that they approved it. And then they had a news conference on January the 17th in New York, and he invited people from NIAAA. Stephanie O'Malley was there, and people from DuPont were there. And I thought this was going to be like a really big deal, and people are going to be really excited about it. It was going to change the field, and it didn't. People, said, "Well, that's nice," and there was a whole lot of resistance in the AA treatment community. They believe you don't treat an addiction with another pill, and in academic circles, it wasn't even incredibly popular because um, naltrexone came from the drug side of the research, and those are people who are into harm reduction and medical approaches to understanding addiction. That was the NIDA side, and the alcohol side was NIAAA, which is mostly into psychosocial treatments, and it was founded by people who had very much sort of a 12-step philosophy. And so even among people in NIAAA in the academic community, it was sort of a poor stepchild. The ironic thing is when naltrexone was approved, it was approved as a orphan drug, which means it's a medicine that didn't have to go through quite as formal process of getting approval because there was, at the time, the only other option was disulfiram. So it was approved as an orphan drug. Then the next phase was unwelcome stepchild in the alcohol treatment community. And now, 30 years later, I think it's being adopted by a grassroots movement. And, you, Steve, and Claudia, and other people have done a fantastic job of creating interest and helping educate people about this remarkable medicine. So I think it's going through sort of a renaissance now, and people are increasingly aware of it and using it effectively. So it's really been an incredible journey. And I can tell you over the past 30 years, all our attempts to try to help educate clinicians about naltrexone, how to educate the general public, how to get companies to cover the treatment with naltrexone. And it's really been a huge uphill battle to get clinicians, patients, insurance coverage to all come together to help people get a prescription and pay for it. But I think all these elements are now coming together now. So this is just a really unique time.
Okay. So it sounds like, if I don't mean to put words in your mouth, but it sounds like basically at the institutional level, it was acknowledged but not embraced.
Yes.
And at the level of the patient, it was unheard of for the most part because it wasn't embraced. And now we're entering into this stage where it's a grassroots movement. It's almost kind of cool,
Yeah.
I, to be
This is pretty unique for a medicine. Virtually all medicines are promoted by the pharmaceutical company, where they help to teach people about how to use it, and they help uh, train doctors how to use it, and they come around to detail the doctors' offices and give them lunches and that sort of thing, so that people understand the medicine. And then you see commercials on television to try and get the general public interested in it. But no one's doing that for naltrexone. There's no pharmaceutical company detailing it. There's no drug reps coming out. I mean, Vivitrol has a couple of drug reps, but they're promoting the injectable version of naltrexone, and even the Alkermes people who have Vivitrol. It's a poor stepchild there too, because it was a drug that was sort of handed to them. They're really interested in promoting their newer products for schizophrenia. So that's what they're spending their time and effort promoting. So it's really a bit of orphan, neglected. When it was approved, it came in under the wire. It's just been something just sort of hanging out there, by itself. And it's it's almost like a person with social anxiety has been off to the side, and now it's time to come out.
right. Right. The new message is that there's a new sobriety kind of thing happening out there. That's probably not the best word, okay, because I know it's full of triggers and stuff, but there's a new relationship that people are starting to embrace with alcohol that is harm reduction based, okay? And so that's what I mean when I say it's almost cool to be taking naltrexone now. And so we can change that story. And some of what you talked about, the naltrexone alliance is formed to take on those roles. You want to talk about that for just a second?
Yeah, so actually the history goes back to our semester with Joe thing that we had going, where we would come here on Thursday nights and help teach people a little bit about the understanding of addiction and some of the really basic concepts. That it was a lot of fun, but probably was more academic than clinical. But if you ever get a chance to go back and look at some of those lectures, that would be fun. But it really gave me an opportunity to understand the passion that people in the community had for understanding naltrexone and how to use it. And that got me excited again that maybe there's something happening. And so talking with you, talking with the folks at Thrive, the folks at OR, we began to put our heads together to sort of figure out how can we advocate for this remarkable medicine. And so in September, we actually came together in person and had a symposium, which one of these days I have to get the video of that up, because it turned out to be just a fantastic day, and we shared a lot of ideas and presented a lot of interesting data. But from that meeting has grown all kinds of subgroups from that people are interested in maybe getting naltrexone label changed. People are interested in how to integrate psychosocial care with that. People are interested in how to get the grassroots community some support so that they can help spread the message. So a variety of different uh, sort of coalitions have come from that are really exciting. So I think it's going to turn out to be one of those really important dates and meetings that really help promote naltrexone.
Yeah, it was a great event, and we had a first live meetup there too, which
We
was
had our
really
first live meetup there. Yes. Yeah,
was
absolutely. And it came from this entity right here.
cool. Um, you brought up a point that this is actually a pretty good segue. So we did the semester last year. We ran it about 8 weeks, and those videos are up and available to people. There's a lot of detail, and you get down into the weeds a lot. But one of the things that came out was towards the end, we had a discussion about sedation drinking or drinking to cope. Okay, and that took a little bit of time to, I think, sink in with some people. And even at the time that you were giving that information to us, you said, this is going to take a while for this to register. You're going to go away and you're going to go, and then you're going to come, and a light bulb's going to go on. And that seems to have happened over the last year. There's a lot of interest in this. There's a lot of recognition that now naltrexone does a lot of things on the compulsion side, and it works in some cases on the sedation side, but it needs some help, it seems like. And so folks, especially folks that maybe have been doing the targeted method of taking naltrexone before drinking with the aim of extinction, sometimes they stall out. Okay, and they're trying to figure out, why have I stalled out? And the hope is here that maybe this discussion this evening will give some people some ideas about things, that additional levers that they can pull.
No, that sounds good. One of the things that we talked about in our semester was how versatile naltrexone was. That many people have come to this group understanding the Sinclair method and have read, with the book, what is it, the Cure for Alcohol Addiction or whatever, alcoholism. Um, and that presents, I would say, sort of one narrow view of how naltrexone works, where you take it an hour or two before drinking, and then the behavior of drinking should extinguish because it's no longer followed by reward. And that's clearly one of the mechanisms, but it's not the only mechanism. And there's two others that we had talked about. And one is that when people are in the presence of cues associated with drinking, that can stimulate craving, that can stimulate the motivation to want to drink. And so someone could have, 3 months without having anything to drink, and then they watch, go to a Super Bowl party, and everyone else there is drinking, and they're having fun. And now it's a situation where they used to drink, and sort of even subconsciously, part of their brain says, you should be drinking now. That would really hit the spot. And a person finds themselves holding a drink in their hand and drinking. And while the behavior is willful, and we talked about voluntary behavior and involuntary behavior, the behavior is willful and voluntary, that you go over and pick up a drink. The motivation for it is not. And a lot of times we do things that are sort of automatic. We do it without using our conscious brain so much. We just do it. And that's one of the factors that can come into play for people in treatment. But naltrexone also has a effect where it seems to help block cue elicited craving, so that you can be in the presence of these cues and it no longer stimulates craving. And over time, what we found is that some people, the cues no longer even elicit craving, even when you don't have naltrexone on board. It's as if the cues have extinguished themselves. So not just the behavior of picking up a drink, which is, we call that instrumental learning, but the sort of unconscious, reflexive, classically conditioned cue associated craving undergoes extinction. And then people will report things like they reached a point of, I think in the community, people call it pharmacologic extinction, but they reach a point where they no longer think about drinking. The idea of drinking has no appeal. And that's the closest thing to a cure that I can think of for this disorder. Where, yeah, I had a patient the other day who told me that um, his daughter just got engaged. And so he had to give a toast for, his friends. Both sides of the family were together, and he raised a glass. And he's holding wine, and he had no desire to drink. It wasn't that he successfully stopped himself from drinking. He didn't want to drink. The thought didn't even cross his mind to drink. It wasn't something he did anymore. And people outside of this community, people out, who recover with AA or with other approaches, don't even, that seems inconceivable. It's the notion is, once you're an alcoholic for life. You have to go to meetings for the rest of your life. You have to always avoid people, places, and things. But with naltrexone, people, places, and things have a chance to extinguish. And you get to a point where it no longer has any power over you. It no longer motivates your behavior. Then there's a third mechanism that we talked about that's real important, and that is um, we could call it priming, if you will. That when someone has two or three drinks and has an alcohol problem, often the two or three drinks increases the craving for the next drink. The act of drinking increases the motivation to drink more. And that seems to be particularly um, common in people who develop alcohol use disorder and not common in people who don't develop alcohol use disorder. I did a study one time where I took people that had a strong family history for drinking and put them in a lab. So these are college students, so they didn't meet the criteria for AUD, but they just had a strong family history for drinking. And I gave them the equivalent of three, and that wasn't the equivalent, it was exactly three beers. And I monitored their response to three beers. And what people reported was initially for the first 45 minutes, they had increased energy, increased euphoria. They got the alcohol high. And after 45 minutes, they started getting tired. And by an hour or two, they were just sleepy. People without a family history for alcohol problems, after three beers, they just got tired. They didn't have that initial phase of excitement and euphoria. When I gave people naltrexone before they had their three beers, the people who had no family history, they just got tired. They acted as if they didn't get naltrexone. They looked like they had placebo. But the people who had the strong family history, when they had naltrexone first, they looked like the people who did not have a family history. They just got tired. It blocked the stimulating effects of the alcohol. It blocked the alcohol high. The most remarkable finding was that after three drinks, people who had a strong family history for alcohol problems, their craving for the fourth drink was higher than the craving for the first drink. The three drinks stimulated more craving for alcohol. They wanted to keep that high going, if you will. When it started going down, they wanted to go back and have another drink to keep that high going. And people without a family history, after three drinks, they were done. They did not want any more alcohol. They were tired. I don't need any more alcohol. I'm good. And so you see that certain biological factors can create a condition where three drinks increase the need, the desire for the fourth drink. And naltrexone blocks that. And in the course of the semester, I suggested that probably the cardinal feature of addiction is the pattern where engaging in the behavior, drinking alcohol, increases the need, the motivation, the craving to want to drink more. And it can happen within one drinking session. That after three drinks, you want to have the fourth drink, even more than the first drink. It can happen between drinking sessions. Someone who drinks and, for example, uses the alcohol to fall asleep. After a while, your body gets used to the alcohol, and then you need the alcohol just to get to sleep. And if you don't have the alcohol, it keeps you up at night. And so that's a different way that drinking can increase the desire for more drinking, but that's over days. That's between sessions, if you will. And that's when we talked about, so those are the three mechanisms.
So
Extinction.
can I want to explore that third mechanism a little bit. So it's easy to understand the idea of the nobody can eat just one, right?
Yes.
Thing. Okay. When you're talking about social drinking. Okay. But I assume that it's the same thing if you're drinking to cope. So that in that particular case, the wearing off, if you will, it's not the wearing off of euphoria, it's the wearing off of the dulling of
Yes.
whatever it is that you're trying, the pain you're trying, that the person's trying to escape.
Yeah, but the
There,
time course is different. So the
okay.
sedative effects of alcohol So alcohol has two primary effects. One is an exciting effect, probably related to endogenous opiates and dopamine, and a sedative effect, which is probably related to increases in GABA activity. When someone drinks to knock themselves out to sleep, after three drinks, they're tired, fall asleep. After three drinks, once they're tired, they don't need any more. They've had enough. But if you do that consistently, day after day, okay, then you need the alcohol just to maintain where you were before you started drinking. So it's an over day effect versus a within one drinking session effect.
Well, that's what I was trying to understand. Okay, so maybe I didn't make my point clear enough. If you're a person that has a family history of drinking, okay,
Yes.
for positive effects, is it
Yep.
also likely that you would see more pronounced effects? In other words, in session drinking withdrawal, if you will, by feeling you weren't getting the dulling that you were trying to get of the pain and therefore drink more? Or does
Yeah.
that just
So
happen in
yeah.
that?
So the usually the positive family history folks are drinking to get the euphoria, not so much the dulling. The people
Okay.
who drink a lot for the dulling are probably not the strong family history.
Okay.
So they're
Okay.
looking for more of a GABA effect versus a endorphin dopamine effect.
Okay, so we're talking more of a long cycle addiction versus a short cycle disruption, if you will.
Yes.
Okay.
Yes. Yeah,
Okay.
exactly.
And what do we do about that?
Okay. So for the short cycle addiction, where three drinks increases the craving for the fourth drink, that's really easy to fix. Take naltrexone. It
Right.
blocks it. It cures that.
Right.
Simple. The problem is that some people, maybe even a lot of people, start out drinking for the euphoria and they wind up having their four drinks and they do that a couple times a week. And what else is happening? Now, in addition to drinking for the euphoria, their body is adapting to the sedative effects of the alcohol. And how does it do that? There's a um, we called it a what was it, a tug rope kind of thing, so that if alcohol stimulates the GABA system, which makes you tired, sedative, the body adapts by having excitatory neurotransmitters like the glutamate system be more active, and the two tend to cancel each other out. So some people report tolerance. What used to get them tired after three drinks now takes six or seven drinks. And that's just a natural physiologic process that occurs for all drinkers. You don't have to have a family history. And now the person starts to get stuck because the drinking helps them to take away the crappy feeling of going through alcohol withdrawal, but the drinking then leads to more withdrawal. So you get stuck in a second kind of vicious cycle that the drinking helps you feel better because it takes away the rebound withdrawal, the increase of glutamate activity relative to GABA activity, but your body then needs more alcohol just to go back to where you were before because you're going to go through withdrawal from that drinking episode. So you can see how then you get stuck through a different mechanism, which is the sedative mechanism. Someone could start out for drinking for the high, but over time, then they get stuck in the sedative mechanism. There are some people who never drank to get high, who always started out drinking for the sedative effects of alcohol, and that's a different group altogether. So you can have three groups: people who just drink for the high, don't have any tolerance to alcohol, no withdrawal, no physiologic adaptation to the sedative effects of alcohol. Just taking naltrexone should work relatively quickly. You can have people who um, drink for, and they started out drinking for the high, for the excitatory effects of alcohol, but over time also develop tolerance to the sedative effects of alcohol. And now they have two things. compelling their drinking. They want to get the high, but they also want to avoid the withdrawal. And then you have a third group that never drank to get the high. They always drank for the sedative effects, but over time their body adapted to the alcohol, and now they need to drink to take away the withdrawal symptoms. So three different groups. So how, then the question is, which gets us to the next topic, is how does naltrexone work? So for some people, I would expect they would have a pretty quick and rapid effective response by taking naltrexone in a targeted way. Maybe over time, the cues associated with drinking will extinguish. So maybe that takes 3 months, 6 months or so. And then the person walks around and they can have a drink and not have it turn into 5 drinks. When they're in the presence of cues associated with drinking, it no longer stimulates a desire where they have to drink. And they look like they're just, the alcohol is not an issue for them anymore. So that's one group. But then you can get people, and then you have some people who they never use the alcohol for its stimulating effects at all. Has nothing to do with the dopamine system, has nothing to do with the endorphin system. For those folks, probably naltrexone doesn't have much use for them, period. Doesn't help very much. And then you have a group in the middle that started out to drink to get the high, but over time developed the sedative effects. And the naltrexone should be helpful for them, but only partially helpful. They might be able to control how many drinks they have within a drinking session, but they still need to drink the next day to avoid possible withdrawal symptoms. So that may be someone who has slow progress with using targeted naltrexone. So that's the thesis, is that some people, if you're having trouble, you might be drinking more for the sedative effects of the alcohol, or you started out drinking to get the high. The naltrexone will help you moderate your drinking, but it's going to take you a long time for your body to detox, if you will, from the alcohol. So
Okay,
hopefully that makes some sense.
it does. So um, let's talk about that group then that starts out euphoric but ends up full cycle.
Yeah.
Okay.
So then the question is how to approach that.
Yes.
And I think there's two ways to approach that. So one way is that now people with naltrexone will be able to moderate the number of drinks that they have. So maybe by keeping track using drinking logs, you can see a gradual reduction in the number of drinks that you have. And over time, your body will need less and less alcohol as it no longer needs alcohol to avoid or take away withdrawal symptoms. So that would be a way to sort of gradually rip the Band-Aid off. Now, for some people, that's a valid way to go. And that's sort of the approach that David Sinclair suggested and Roy Scapa in the book, just gradually cut down on your drinking. Now, it's a valid approach, but for me, I'm a little bit concerned about that because that means that there's going to be some days with a person is going to have 5 or 6 drinks to avoid the withdrawal, and 5 or 6 drinks is not healthy for you, not healthy for anybody. Alcohol, they're thinking about putting, I guess, warnings on the bottle, can be carcinogenic. Alcohol can cause problems with inflammation for the liver, for your muscles, for nerve cells. And so if it takes you, 12 months and you're still drinking 4 or 5 drinks a day, you're still doing damage to your body. So the other approach, and this is one that's not advocated by the Sinclair method uh, advocates, is to first do a detox. So we take away drinking for the sedative effects. We take away that physiologic adaptation. And there's ways to detox from alcohol in an outpatient setting using medicines like either benzodiazepines, Tegretol, or Neurontin that restore the equilibrium, if you will, between the GABA system and the glutamate system. So that no longer motivates your drinking. And after a period of time, your body is no longer dependent on using alcohol to restore that equilibrium. And then the naltrexone can come in and block the high drinking, and then the person can get to the same point as someone who um, didn't have that physiologic adaptation. So they can look like one of those rapid responders. So that will be a way of ripping the Band-Aid off all at once. So you go through a detox first, then you go on naltrexone, and then you should have the same kind of effect that someone has who doesn't have that physiologic adaptation, is not a heavy long-term drinker.
Yeah, and so to be clear, we're not talking about like um, a severe case, okay? We're talking about that would require inpatient care,
Right.
okay? We're
Mm.
talking about someone that can detox safely under medical supervision at home. Nobody has to really know about it other than that person and their doctor. It doesn't have to be a big deal, I guess, is what I'm saying. There's
No,
it's
I,
not like
you know,
a 30-day rehab stint kind of
you
thing.
don't need a 28-day rehab. You don't need to go into a hospital for 7 days. I set up a protocol when I was at the VA hospital in Philadelphia way back in actually the mid 70s. And it was really easy to use. People who had medical problems did better inpatient. People who had a history of bad withdrawal seizures, better inpatient. People who had a history of delirium tremens, severe withdrawal symptoms, did better inpatient. And some people, just for whatever reason, weren't able to stop drinking by themselves in an outpatient setting. They did better inpatient. But the vast majority of people were able to do it successfully in an outpatient setting. And actually, we published a paper in the New England Journal of Medicine, pretty good journal, and we showed that the outpatient worked just as well as inpatient. It was like 1/10 the cost. So you could talk to your doctor about doing that, and that's a very successful way of getting your body off the alcohol, then onto the naltrexone, and you're more likely to have a quicker response from the naltrexone.
Yeah. Okay. So either a person can self-select in advance, knowing kind of where they are on the drinking spectrum, what makes the most sense. Should they go for the rip the band-aid off fast, and
Hmm.
then the medication is going to be more successful for them, or do they taper? Okay. And probably the reality is a lot of people try the tapering thing first. Okay, because it's
Hmm.
just easier. Okay, they're already going to take naltrexone, and so they try that. And but at some point, a person has to recognize that you've kind of reached the limitations of what you can do at that point, and maybe
Yeah.
another measure is.
Yeah, I saw one comment that someone said that their doctor won't use outpatient detox. And I would say, I would find a doctor that is comfortable using it. It's not a controversial procedure. They tell the doctor to look at the up-to-date book. So this is a Bible that doctors carry around with them that gives you advice in terms of how to treat the infections or what antibiotics to use and how to treat diabetes. Anyway, there's a chapter on how to do outpatient detox. And so they can learn how to do it. It's very easy. I used to have a protocol for physician assistants and nurse practitioners, and I would train them how to do it, and they did a spectacular job. So it's not very hard. It's a simple protocol, and one can easily implement it, and you get really good results.
Great, great. Let's take a look at some questions that are popped up here. Make sure that we're picking those. Um, we've got. Bear with me here. Drinking to cope for sedation, how TSM works. Okay, I think we kind of covered that a little bit. Here's a question. Experiencing anger and frustration after taking naltrexone. Have you run into that with folks? And if not, why? Damn it.
Yeah, so a couple things can come into play here. So there are people who, instead of going through detoxification first, they start with naltrexone. And sometimes I think, well, they should do fine because, they're not likely to have bad withdrawal symptoms. But what happens is that if you go into a situation where your body expects it's going to get a big burst of pleasure, but you block that with naltrexone, and it doesn't get what it was looking for, your body's going to be a little bit upset. I mean, we see that in rats all the time. They call it a extinction burst, if you will. That it was expecting something, it didn't show up. And it's like then the rat starts pounding on the bar harder and harder. Where's that food pellet? I want it. And so your part of your brain is going to be a little bit disappointed that it's not getting that reward that it thought it was going to get. So that's one mechanism. A second mechanism is that if you are going through a little bit of withdrawal, um, it can be experienced as frustration and anger. That your body is physiologically aroused. You're a little bit more into fight or flight. You're a little bit more jazzed up. Your heart rate is faster. You're sweating. And even if you don't have those obvious symptoms, your nerves are more irritable. And so some people attribute that to the naltrexone, but it's probably more likely that there's a change in your alcohol drinking that's causing those symptoms.
Mhm.
There are some people who, even after they complete detox, they're uh, even after they complete detox, their nerves are still irritable. We call it post-acute withdrawal symptoms. So that can last for months, where you still feel out of sorts. You can be feeling calm, but then something sets you off and you react more anxiously or aggressively than you would normally because your body still isn't in good equilibrium. It's if you injure a limb, even after the bone has healed, it still hurts in that area for a while, and it just takes a while for your body to completely heal. So that could be part of it. Is it a direct effect of naltrexone? Probably not. So people who are not addicted to opiates, don't have problems with alcohol, if you give them naltrexone, it doesn't really do much one way or the other. So now, having said that, different people have different side effects, and I don't deny any side effects that you might have. But those are what I find when I really, get into the weeds. Those are usually the two factors that people are disappointed that they're not getting the high, or it's contributing to a bit of withdrawal, and withdrawal can be interpreted as anger and frustration.
Yeah, it's interesting. There's some emotional aspects of naltrexone that are exhibited that people oftentimes confuse as being side effects, okay, rather than the physiological changes that are occurring in them because of reduced alcohol intake. That irritation is one. It's interesting you use the term extinction burst there with respect to the rats. Extinction burst is used quite a bit in the TSM vernacular as being that sort of last gasp when somebody sees their drinking numbers go up, spike drastically. Usually that's called an extinction burst. Okay. It's the toddler brain saying, give me that lollipop. Damn it. So it's a subtle difference, but I think they're connected. Um, hmm. It's boy, this is a really complex disorder. A lot of times, everything.
I mean, it's simple, but to fully understand it, you have to bring in a couple other concepts. So,
Right, right, right. I think that a similar kind of what's called side effect might be the one where people report dizziness or spaciness, maybe is a
mhm.
better one. Okay. And that seems like that's probably more related to you were expecting a reward and all of a sudden you didn't get it. And so your brain is confused.
Disoriented. Yeah,
It's
yeah,
disoriented. It didn't get what it expected, and it's not really because you're taking the naltrexone. Well, it is. I mean, but it's not. It's the blocking of the endorphins and the dopamine that is the expect. That's unexpected, and that occurs.
yeah. So it turns out when you expect a good thing and you don't get it, it's not. just neutral. It's you're mad. It's you're worse than if you don't expect it at all and you don't get it. If you don't get something and you didn't expect something, you're flat. If you
Oh
expect
yeah.
something good and you don't get it, you're not flat. You're negative.
Yep. Yep. Okay, let's see. We had a question on, can you give a quick rundown on how detox works?
Hmm.
Not sure if that's been completely covered. The person that asked the question, I would ask you to just, let us know if you think you've gotten sufficient answer on that question or not.
Well, so I'll quickly go through the protocol so you can help teach your doctor this if they don't know how to do it. So basically, I use targeted medicines for detox. I use a targeted approach there. And so um, I'll have an instrument that measures the severity of withdrawal. And often when people first come in, they've had something to drink recently, so they're not in withdrawal yet. So what I'll do is I'll give them a medicine. Their three favorite ones of mine are oxazepam, it's a benzodiazepine, Tegretol, and Neurontin, gabapentin. And the doses are 30 milligrams for oxazepam, uh, and I have standard doses for the other medicines. And you take one every 4 hours as needed. So you pick one of those medicines you're going to detox with, and you take it every 4 hours as needed. And I say if you're sleeping, don't wake up to take the medicine. It means you don't need it. And then I have people come back into the office the next day, and I ask them how they did and how much of the medicine they needed to feel better. And so some people say I needed uh, five of them. Then I'll say, okay, for today, the next 24 hours, I want you to get by with just four, and then three, two, one, then they're done. So typically they'll say they needed four of the Tegretol or Neurontins, and then it'll take it 3, 4, 5 days to gradually wean off the alcohol, and then you just stop. And then at that point, I usually start the naltrexone. So very simple procedure. I usually ask people to show up in the office so I can measure the severity of their withdrawal. So I can look at their heart rate, look at their blood pressure, see if they're sweating. Um, what we're doing a little bit more now, and we had to do it during COVID, is that um, when people can't come into the office, sometimes we've been having virtual visits on the internet where I can see them, but they're not in person, and I could help manage their withdrawal that way. But if you can do it in person, you get a little bit more data that way. So that procedure, I found about 80% of people who start the detox are able to complete the detox in an outpatient setting.
In your clinical experience, do you find that folks that do detox tend to respond better? I know that's a difficult question to answer because each one is a sample size of n as one.
Right. So
No, but
I'll tell you the protocol that I use, that when people detox and they have a history of mild or moderate withdrawal symptoms, I usually suggest the first month the goal is not to drink any alcohol at all. And the idea is just give your body a chance to adapt to not having alcohol in it. I say, if you had a wound, you can't keep poking at it for it to heal altogether. Just give yourself 30 days no drinking. After that, I still recommend that they take naltrexone every single day. But if they want to introduce some drinking, they can, so long as I used to say, so you don't have a heavy drinking day, which is four or more for females, five or more for males. I'm pushing that down a little bit more because there's some data that alcohol, even between 2 and 5 drinks, might have some bad effects. There's a big debate in the literature about, is alcohol safe at any level now? But between 2 and 5 is one of those gray areas. So I ask people to shoot for no more than a drink or two for females and no more than 2 drinks, up to 3 drinks or so for males. Try and keep that as the goal. And if they're able to do it by taking naltrexone, that's a very reasonable outcome. After a period of time when people are doing well, for me, that's usually at least 6 months, if not a year. That's when I usually move more toward a targeted naltrexone approach, or just take naltrexone when your craving is high, or if you're going to be in a high risk situation, or if you're planning to drink, take it before you drink. And that protocol works pretty well. There are some people who come in and say, no, I don't need a detox. I only drink on weekends. And I don't like the idea of having 6 drinks on a weekend. I want to keep it down to just, 2 or 3. And for people who are look who have those characteristics, then I'll start targeting naltrexone right away if that's their
Okay.
goal.
So, a couple things. Um, you're not trying to force abstinence on people, right?
No,
That is
no.
not the goal. The goal here is harm reduction.
Goal
But
here is a healthy, happy life. That's my
right,
goal for people.
goals, okay, it's beyond harm reduction. So
Yes.
it is a step beyond that. Okay.
Yeah.
Path to getting there, though, might be blocked by a severe AUD, and
Mhm.
taking some big steps might be necessary in order to be able to move ahead quickly. That might be an impossible ask for some people.
Mhm.
Okay. Um, so in the numbers that you talked about, I mean, those are good numbers if people can achieve them. A lot of times people are coming with much, much higher numbers. Okay.
Yes.
So,
So
but
there's plenty of data now that says, and they're beginning to look at this in research studies, that the World Health Organization classifies people by the severity of their addiction. And so you can be level 1, 2, 3, or 4. So if you go from a 4 to a 2, so from a severe alcohol problem to just a moderate problem, there's tremendous health benefits for doing that. If you go from a 2 to a 1, there's health benefits associated with that. And so that's a really good example of harm reduction. And that's a very useful outcome. In the old days, when I studied, you know, uh, or the AA model, if someone reduced their drinking but continued to drink once in a while, that was considered a failure. And actually, in the treatment programs, people would get kicked out for that. It's hard to imagine now, but they say, well, you're not motivated. Come back when you're ready. Come back when you hit rock bottom. If you're still going to once a month go out and have 5 drinks, you're a failure, and you have to start counting from day one and all that kind of stuff. And so that was really frowned upon. The We began to look at that not as failures, but as learning opportunities. What went into having that binge? Did you take the naltrexone ahead of time? Or if you're not taking naltrexone, maybe that's a good idea to add naltrexone to your treatment. What else was going on in your life? Were you drinking out of spite? Were you drinking to get the high? Were you drinking because you couldn't sleep at night and you needed something to help sedate you? To try to understand what went into that slip, relapse, and then to do something about it, to try and give people more tools so it didn't happen in the future. But then also for people to look at that slip and say, what went into causing it and what were the effects of it, so that people can see that I was talking to a patient actually earlier today who I've been working with this guy for a long time, and he refuses to quit drinking. And he drinks, he says, for sleep, but he also drinks a lot when he's stressed. And he decided to do a dry January. And he did great until this past weekend. But what he noticed is that when he had 3 weeks of no drinking under his belt, he felt so much better physically. He was getting along better with people. He didn't realize how the alcohol was having so many adverse effects. And then when he had the slip up this past weekend, he noticed that his sleep, which was improving, he got one of those watches that measures his sleep. So without the alcohol this month, his sleep was getting great. He scored 800 on his sleep score, his new record. So after his slip, his sleep got all fouled up again. And so in his mind, he was thinking he was using alcohol to get to sleep. But when we looked at the data, his sleep was all fouled up during the time when he was drinking a lot and improved significantly when he stopped drinking. And then when he had the foul up again, if you will, the drinking episode, the sleep got messed up again. So he could begin to shine a light on the tracks, if you will. He could see how his drinking was leading to these adverse effects. And that is incredibly motivating for him to say, okay, that's it. I'm going back to, I just did a dry January. I'm going to try a dry February. I actually feel better. But it wasn't that I convinced him or he got pressure from people. It was that he could see the data himself. And so I'm all in favor of harm reduction. That's the point. But if someone's still in harm, I don't like to leave them there. I meet people where they're at. But if they're in a bad place, I don't leave them there. I try and move them along so that they make improvement over time and continue to get to a place where they want to be, not where I think they should be, but where they want to be with their drinking. And and that's why I approach my psychosocial support to help people in the recovery.
Yeah, and why don't we go and talk about that a little bit? That would be your Brenda
Hmm.
process. Can you fill us in on that? And there's some exciting things going on with that right now too, with AI and being able to broaden the distribution of those skills, I guess.
Yeah. So one of the things that I found is so David Sinclair and I were both scientists working in research labs with rats in the 70s and 80s. And we found naltrexone reduced alcohol drinking in these animal models. Now, when I started working with humans, I found something was dramatically different. With the rats, I would give them an injection of naltrexone before the opportunity to drink. Same thing with David Sinclair. The rats had no choice. For humans, when I would write for a prescription, humans would have a choice if they're going to take the pill or not. And some people would take the pill, they'd start drinking, they wouldn't get the high, they would stop drinking after one or two drinks, and I'd say, see, success. How naive. Because then when I would talk to them the next week, they would say, yeah, it blocked my high from drinking. But on the weekend, I stopped taking the naltrexone because I wanted to get the high. And so I realized if you just write a prescription for naltrexone, a lot of times it's not going to be all that effective unless you can get the person on board with wanting to get a naltrexone effect. In other words, not get the high from drinking. Now, I have to say that sometimes people will come in on a Monday after a bad weekend of drinking and they'd be all in favor of taking naltrexone. They promised their spouse they would take it. They were really 100% on board. They were going to take the naltrexone. And usually they would drink on the weekends, and the weekend is still far away. But as the weekend got closer, their motivation to take the naltrexone began to wane. And instead of seeing all the good long-term beneficial effects of not having an episode of heavy drinking, they saw the immediate good effects of how good the alcohol would make them feel. And so the motivation to take the naltrexone would wane over the course of the week. So I said, if I'm going to do research in this area, I want to show that naltrexone is effective. And to have people not being consistent with taking the pill is going to mess up the research. And worse, some people would just drop out of treatment altogether. They say, this isn't working, and they quit coming in. So I said, let me design some sort of psychosocial approach to help engage people in treatment, get them to be consistent with taking their medicine, get them to stay in treatment. And we call that the Brenda approach. And we call it the Brenda approaches because that refers to the various steps that you take in terms of working with patients. The B stands for biopsychosocial evaluation. So you want to take a snapshot of where people are in their course and their journey with the alcohol. And so when people first come in, we might find that their liver enzymes are elevated. They're having problems with their spouse. They show up for work intoxicated or in withdrawal. They feel crappy about themselves. They feel anxious. They feel depressed. You get a snapshot of where they are along biological, psychological, and social domains. And the other part of Brenda is you give people feedback or you give people a report about how the alcohol drinking is having adverse effects. And you'd be surprised. A lot of people who've been drinking for a long time um, either ignore or don't realize how many bad effects they're getting from the alcohol. And they might see their drinking as well. All my friends drink a lot. I'm not drinking much more than them. You know, I'm not happy in my relationship because my wife is a pain in the rear end, as opposed to she's a pain in the rear end because you're showing up, intoxicated when you come home from work. So when you give people a report, you want to give them a non-judgmental, like you shouldn't be doing this, non-judgmental, just a matter of fact report of the data. This is what we find. I notice on weekends you drink X amount, and on Mondays when you wake up for work, you feel crappy. That's probably the withdrawal from the alcohol. I notice the evenings when you go out with buddies and drink a lot, you wind up having a fight with your spouse when you come home. I notice we looked at your blood work and we see your liver enzymes are elevated. All these things are likely related to the amount of drinking that you're doing. And when you do that, again, non-judgmental, you want to get a sense of what it's like from the patient's perspective, empathy. How do they feel about you, the information that you're giving them? Some people say, no, 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 I don't buy it. Drinking has nothing to do with the relationship with my wife. If she was nicer, I wouldn't drink or something like that. So I'll have a whole bunch of different things. But in in talking to them about how the alcohol may be affecting their life and looking at it from an empathetic perspective, you get a sense of what the patient's needs are, what's important for them, what are their goals. And then for some people, it might be, I don't like the fact that my liver enzymes are elevated. That bothers me. So their need is to reduce their liver enzymes. For someone else, it might be, I really love my daughter and I don't feel close to her and she's upset about my drinking. That's something that I want to change. So you find a hook for each person. You find what the most important need is. And then you give the direct advice. Then you say, because you want to lower your liver enzymes, because you want to improve your relationship with your daughter, because you want to feel better physically, that's when I suggest we do X, Y, and Z. And the X, Y, and Z could be, I think you need to do a detox. The X, Y, and Z could be, I think you need to go on naltrexone or some other medicine or go to meetings or whatever. But the direct advice that you give, from my perspective at least, should be evidence-based and tailored for that particular person. And what you find is if a person feels that you know them, when a person feels that you have their best interests at heart, when a person feels like you're addressing needs that are important to them, then they're likely to go along with your suggestion. And if you don't do that, they're not likely to go along with your suggestion. So then you might say, I think you need to take targeted naltrexone 50 milligrams an hour or two before every drinking episode. And here's the data that shows how effective it is for people like you. And you're likely to get people to comply with that, to adhere to that recommendation. But even so, after the D, you have to assess the response to your direct advice. And some people will go along with it and say, I tried your suggestion, it works perfectly. Other people might say that they're really going to do it. Then you talk to them the next week and they didn't do it. Some people within that session will say, Doc, you want me to take this pill, but I just don't believe in pills. So you're not ready to take the naltrexone. And for people who are not ready, you don't say, come back when you're ready. You don't try to hit people over the head with, you should be ready. I hardly ever like, use the word should. That's such a bad word for me. But to say, let me understand why you don't want to take it. And it might be that they're worried it's too expensive. They might worry that it shows up in their urine and their employer is going to find out that they're taking a pill. There might be embarrassment, shame. There's a whole bunch of reasons that could go into it. Part of my job is to work with them to try to understand what's going on and maybe answer any questions that they might have. And hopefully I can move someone who's, we call in the contemplative step, where they're thinking that they might do it, to the action step, where they're ready to do it. Or some people who are non-contemplative, they believe, I don't think drinking is a problem at all. I'm not going to do any of your recommendations. Sometimes I bargain with people a little bit and say, look, I know you believe that you have control over your drinking, that you don't have a problem, but how about for the next 2 weeks, let's really limit your drinking to no more than, say, 2 drinks a day. And I know you can control it. You told me you can control it. So let's see how you do over the next couple weeks and see how you feel. And if you feel fine, great. If you don't feel great, maybe we can try, using this medicine or something. And And so that's the most I can get in that particular session. They come back and then we review what happened. And a lot of times people say, I tried to control my drinking, but I wasn't able to. Maybe I do have a problem. Okay, I'll take your pill. And so that's how you get people to move along the stages of change. And that's the Brenda approach. And what we found is in our research, it improved people's retention. It was easier to show that there was an effect of naltrexone relative to placebo. Some of the studies that didn't use Brenda, they didn't find any differences. So there was a big controversy in the literature if naltrexone worked or not. But in general, the studies that used this approach or something like this approach had much better results, that naltrexone worked better than the placebo or the sugar pill. And so when I left Penn in 2008, I was a tenured professor at Penn. And after 25 years, I left, retired from Penn, didn't even leave it. I'm still part of the faculty there as a emeritus, but I, um, I retired from Penn to set up the Volpicelli Center because people weren't really using naltrexone. That gets back to the 30-year thing, that people weren't using it. And people who were using naltrexone basically were just giving people a prescription. So I said, what would happen if we combine the medicine with the Brenda and see how that would work in clinical practice? And so that's what I did. And we found that we had really good retention. And so I've been trying to teach people about how to integrate Brenda in the clinical practice. And it'd be fun to take a poll here of the people here to see what percent of people, when they got their prescription for naltrexone, were also offered some sort of psychosocial support to be used in conjunction with the medicine. Now, it does not count that they say go to meetings and take the pill, because at the meetings you're not going to get psychosocial support that's integrated with the medicine. It doesn't count if you see a addiction counselor who never heard about naltrexone. It's somebody who's doing psychosocial support who also knows about naltrexone and knows how to use it. That's what I'm talking about. And I mean, have people here had that experience or not? Because
Uh, Anybody that has had that experience want to chime in?
I can say that my therapist she knew the name of it, but she wasn't real supportive. Didn't prescribe it as targeted.
yeah, yeah, and so yeah, a lot of people's experience is that they, number one, they have a hard time talking their doctor into writing for the naltrexone, and then when they do talk their doctor into naltrexone, the doctor doesn't offer them any kind of psychosocial support in terms of how to use it, and and so that's why this group in here is so darn important, because you can get peer support free to help you in your journey. Some
Yes.
people will use Thrive, some people will use other kind of coaches, or hopefully find somebody else in the um, a counselor who knows about it. But a lot of times you're not going to find any counselors that know about this stuff that can integrate it. But here in this space, we have peers who know probably more about naltrexone than many of the counselors. It can help support you.
Yes.
And that's the beauty of this Discord group and these TSM meetings that Steve is presenting. It's a fantastic opportunity to work with other people and understand more about the disorder. And if you have questions, you can put questions in the chat and hear other people's experience. But it sort of replaces something that I believe, and I don't like the word should, but it would be really good if this was incorporated in every treatment program.
It would.
And
And I think it's getting to be more like mainstream, more aware. Like I don't know if I shared this with Steve, but my husband signed up for his colonoscopy, and one of the questions was, "Are you taking naltrexone?"
oh my God.
I know,
Wow.
never heard it before.
Wow. See that something's happening.
Yes, so it's getting to
Something
be.
is happening. So the doctors are getting more aware of it. Even the residential treatment programs are offering it to people now. There's something happening, and I attribute it to grassroots movement that people are demanding it from their doctors, and doctors have to look it up.
Yes.
So it's you are doing it. You are literally changing the field. You're bringing the doctors along. You're bringing the rehab programs along, and hopefully we can get the interest of even some of the pharmaceutical companies to understand that this space it deserves their attention. How many pharmaceutical companies are developing new medicines? Maybe we'll get the GLP-1 agonist, the semaglutides, and that sort of thing. But that's purely by accident.
Yeah.
No one says, "Oh, I want to develop a new medicine to help people with alcohol use disorder." Don't say it. They haven't made any money on it yet.
Yeah. Hmm.
But it's happening.
Um, so we talked about detox as one. I'm going to circle back around to sedation drinking for a
Sure.
moment, okay, and potential tools that people can use. So we talked about detox, okay, and that's going to work for some folks, and some folks just aren't going to be ready for it, okay, and they'll approach it whenever it works for them. But I wanted to talk a little bit more about this GABA glutamate dysregulation. And you mentioned gabapentin as one potential medication that could be helpful. The other thing that I think is worth exploring is the idea of polyvagal theory.
Hmm.
And the idea that we can exercise some control over the parasympathetic branch of our autonomic nervous system, and that folks is basically the brake pedal. Okay, so we've got an accelerator in terms of the sympathetic side, and we've got a brake pedal. And like with this was the amazing thing to me when I started learning about polyvagal theory is that you can actually tone your nervous system. I mean, I was like, yeah, you can tone muscles, but you can tone the nervous system. And the answer to that is yes. And not only can you tone it, but you can measure the toning of it through heart rate variability. Okay. And the way to think of that, it's kind of counterintuitive. Heart rate variability, you would typically you might think that you want the number to be low, but the answer to that is not that. You want the number to be high because what heart rate variability is measuring, it's measuring the variability, the beat to beat variability. So the variability within the beats, if you will. And the easier way to think about it is like this. If you have a sports car, you want to have a really good accelerator pedal on that, but you also want to have a really good brake pedal when it comes time for the curves. Okay. And so we spend a lot of the time, quote unquote, exercising the sympathetic side, okay, the side that is associated with fight or flight, okay. And the reason I say that is because we encounter a lot of anxious moments in our days, okay. We're not out fighting saber-toothed tigers, but if you fight a saber-toothed tiger, you either win or lose. It's kind of over, If you're fighting, traffic every day, there's no winning. It's just losing, And so the consequence of that is that a lot of us probably have hyperactive uh, sympathetic sides and don't spend nearly enough time on the parasympathetic side. And that's what polyvagal theory is really aimed at, is how can we exercise this other side so that we can invoke it to slow things down. And it seems to me like there's also two cycles of that. You can do short cycle things that will activate your parasympathetic or activate the brake pedal, and you can do longer cycle things. Okay. So when I think about longer cycle things, I think about like the neuroplastic changes that occur with meditation over time, or breath work over time, the biological changes that occur. But you can also invoke breath work like immediately if you're confronting some particular anxious moment. Or you can splash water on your face. There's things that you can do really quickly to calm down. And then there's things that take time, but I would argue are well worth the time and the investment, because when you invoke those longer term ones, at least my experience is they're more powerful. Okay. So do you have experience with that sort of stuff there, Joe? I knew it's kind of.
Let me tell you a story of a patient I saw today who he has pyuresis. So do people know what that is? It's basically shy bladder. So when he's around other people, he can't go to the bathroom. He can't pee. He's had this for 50 years, and it's really significantly affected his life because he would, if he goes out to dinner, if he goes to a play, goes to a movie, he can't go to the bathroom in front of other people. And so he's limited his social interactions, and it's always something in the back of his mind. If it's a bathroom that has stalls or whatever that he can use, he can sometimes get by with that. But when he stands at a urinal, he starts getting anxious, and then the ability to start his urine stream just goes out the window. So I was telling him about a breath technique where you inhale at a 4 count, you hold it for 4, you exhale for 6, and then 2 to reset the cycle. And so we practiced it a couple times. Today I talked to him. He says he's been doing this and it went away. He's able to urinate. And then he says he doesn't even have to do the breath work anymore, because before, when he would be standing at the urinal, he have anticipatory anxiety. His sympathetic system was so hyperactive that he couldn't start his stream. And then if he had trouble starting his stream, that would further make his sympathetic nervous system more hyperactive. And he'd be stuck in a terrible loop. But now he goes in there and he says, well, if I start to stream, fine. If I don't, I'll do some of the breath exercises, and then I'll start it. And he says he doesn't even have the anticipatory anxiety anymore. He feels that he has control over the darn thing. So he doesn't even have to do the breathing so much. But for him, what helped was to be able to get his vagal tone going to relax the smooth muscle at the sphincter to allow the urine to pass. So I think something like that can also be helpful for people who have insomnia. That, if I say alcohol drinking is not a very good strategy for dealing with insomnia, people say, well, then how am I going to get to sleep? When I talk to people, often they'll say, I sit in the bed and I look at the alarm clock and I see that it's 2 a.m. and I have to wake up early the next day. What if I don't get any sleep? And what keeps them up is that their sympathetic nervous system is hyperactive. And then the longer it goes or they're not sleeping, the more the sympathetic nervous system even gets more active. And so, again, it creates a terrible vicious cycle where they can't fall asleep. And so teaching them how to get the vagal system to be more active has been helpful to say, don't put pressure that you have to go to sleep. It's not the end of the world if you don't get sleep. Instead, try those breathing exercises, try listening to music, put on one of my podcasts or whatever. That'll put you to sleep. And uh, then people get the idea that it's okay if I'm having trouble sleeping tonight, and then their sleep improves. So to the idea of being able to use some technique, and breathing is a good way, you're right, for the short term to do it. And I think meditation, exercise, healthy lifestyle is really good for long term. You need to turn it off. Our sympathetic nervous system was designed for short burst, that basically it's fine if you get it energized for like 30 minutes. And in nature, usually in 30 minutes, either you beat up your opponent, you ran away, or you got eaten. But something happened within 30 minutes. You don't need to be stressed all the time. But in today's society, it's like there's no time to turn it off.
Right.
When do you have a chance to relax? And at least there was a time where you would work and come home and you could relax, but now you have all kinds of phones and this and that. So you're always sort of tethered to work. You have a get an email from your job. You have or there's stress in the family that gets you going. So when do you have a time to just turn it off, to get the parasympathetic system energized? And you're absolutely right. You need a system that can go off and on, not chronically on, not chronically off, but something that is flexible enough to adapt to the situation. When you go from laying down to standing up, you want the sympathetic system to kick in quickly, or else your blood pressure will be too low.
Right.
But you don't want the sympathetic system generalize, arouse for 6 hours at a time. It's like a jet that has its afterburners on. You use up all the fuel, and then people crash after that. They have no sympathetic fuel left, and then they crash. That's not healthy. That's not healthy. So normally we don't have much time, much difficulty getting the sympathetic system going, but we have a hard time figuring out how to get the parasympathetic system going. And so age-old techniques like breathing and exercise and all that can be really helpful. So I don't know. Do you have any other good techniques to get the parasympathetic system going?
Yeah, yeah, I do actually have other techniques, but I wanted to draw the linkage, okay, because the when I talked about long cycle and short cycle, I was actually talking more about the training cycle. Okay, so for example, I've been doing breath work for probably 6 years now. Okay, so I'm pretty experienced at it. I can invoke. I'll do to go to sleep, for example. You use exhale focused breathing. Okay, what you want to do is you want to purge the CO2 out, because the CO2 is what creates the cortisol. Okay, the adrenaline gets you going. And so by breathing out more than you breathe in, you're purging that out. So I'll do a 5-7. Okay, inhale to a count of 5, exhale to a count of 7.
Hmm.
I would say now, in 80% of the cases where I need to get to sleep and I feel like I can't get to sleep, I will do about 2 cycles of that. And midway through the second cycle, I'll go, this isn't going to,
Yeah.
I'm out. Okay. And the big test of that was I was in Miami when they had that big problem about 4 months ago where all the flights were shut down, like 5,000 of them, everything. Miami, this is 3 a.m. at Miami airport. Everybody, there were thousands of people everywhere. I just went over into a corner, did my 5-7 breathing. I was out and sleeping for a couple hours after
That's
that.
great.
It
That's
worked like a charm. But that's because I've done breath work for many, many years. Okay, now you can do some of these like short term fixes quick, like the what you talked about, box breathing.
yeah.
Okay, I had an experience very similar, different than what your client was talking about, but similar in many ways. When I was young, I got bitten by a German Shepherd. I was about 8 years old. It was very traumatic for me, and I was afraid of big dogs for a long, long time in my life. And about 4 or 5 years ago, no, probably about 3 or 4 years ago, because I was pretty well in breath work at that time, I was out hiking around the property that I happen to be at right now. And I turned a corner and there was a mastiff terrier off leash, foaming at the mouth, in full attack mode, running at me. And I just stopped and I box breathe. I did box breathing, the 4 4 4 4. Okay. And at the same time, started sending positive vibrations to the dog saying, hey, you don't want to bite me. I don't taste good. And that. And the interesting thing was, I was wearing a polar watch. I was able to go home later on and isolate that exact instant. Okay. And what I saw was that my my heart rate went up 22 points in about 17 seconds, and it went down 24 points in about 15 seconds. You could see that
That's
spike happen. And
yeah.
it was breath work and the positive thinking that was able to overcome that. I'm absolutely convinced.
So here's a trick that I'm using for myself and for other people who say, I can't do meditation, I can't do breath work, I can't focus, that sort of thing. But you can get at any drugstore a pulse oximeter. So it measures your heart rate and your oxygen. And the goal is to see a 30-point difference between your oxygen level and your heart rate. So if you can get your oxygen to 99, you get your pulse down to 69, you're in a sort of a parasympathetic state. And you get the immediate feedback because you can see what your pulse is, you can see what the oxygen is, your blood oxygen, and so you can uh, whatever you're doing to get it down, you can learn that that's the best strategy to do that. So people who need immediate feedback, and you can get it for a $25 pulse oximeter.
I like that because I've been trying to get a good device to measure heart rate variability. And it's very difficult because it seems to get it confused with atrial fibrillation.
Fibrillation. Yeah.
Like, yeah. So, but
But you
okay,
don't.
and other techniques towards calming the parasympathetic, one of the ones that is highly recommended is contact, connection, being together with other people. And sometimes that's tough when you're in a position where you're anxious and so forth. But I would just tell folks that's what this community is here for. Okay, this is the place to come and make that connection. So if you're feeling anxious, dial into Discord or jump on one of these meetings. So that's a great tool. Another tool is flow, create and flow. So connect and create and get out in nature. Those are probably the three big hitters when you get past like meditation and breath work, which take longer to develop those skills. You can go outside in a heartbeat. Okay, that doesn't take too much of the way of skill. And the best thing is if you can stack these things up. So if you met somebody outside for a nice meal on a sunny day, you're probably going to be hitting on all cylinders of parasympathetic. You're going to be in a pretty good state. And so a lot of times you can just, follow your intuition in that sense. But I would encourage people, if you're interested in this, there's a lot of literature out on polyvagal theory now. Stephen Porges was the guy that kind of started it, but it's interwoven with positive psychology, Marty Seligman, Joe's old colleague, and
Mentor.
and flow.
Yeah.
Those are all intimately connected.
Yeah, I mean that's worth a whole discussion itself, that recovery is more than just not drinking or even drinking in moderation. Recovery is about, I'm sorry, I stole your line. I didn't give you proper attribution. I just used it the other day. It's discovery, not just recovery, it's discovery. It's to be open to the wide variety of beautiful things out there, not just to focus on just the alcohol or whatever your addiction is, but to take advantage of the whole smorgasbord that life has to offer and to discover it. And it's it's more than not feeling bad, it's feeling good. That's the goal here, is to fill that hole that alcohol, you know, when you don't have alcohol in your life anymore, some people still feel a hole there, that there's something missing. Fill that hole with good, healthy things. And connection with people is an important thing. Having some purpose in life, something that you can really get involved with, that you love, that you feel like waking up in the morning. All these are really important. And that's what you know, that's why we do all this. That's why we want to get rid of the alcohol, because it keeps us from getting into that state where we're enjoying life, not just surviving.
That's a great end point, I think. I mean, that's really what this is about. It's yeah, to stop feeling bad because that's kind of the immediate thing, but that's not really the end game. The end game is to discover new
Do
life and things that you missed
do
out
we
on.
mess up again, Steve? I always talk too much and people don't have a chance to ask questions.
No,
We're
no,
talking. They were
I,
going to have ask me anything, and then I wind up talking for an hour and a
no, I was checking to
half.
make sure that we're picking off questions as they come up, and I
Oh,
think
okay.
I got them. But I started out by telling everybody that you can speak, raise your hand, no problem. So I hopefully nobody felt constrained. But that being the case, is anybody got any questions that haven't been addressed? Now's the time to do it. You got the world's expert here.
If I could ask an expanding question, I guess, Dr. V, we talked about sedation drinking as it relates to alleviating the physical sort of GABA glutamate imbalance. But a lot of people, and this pops up on calls all the time, people are drinking for more emotional regulation.
Hmm.
So they're drinking, and 3 or 4 drinks changes their emotional state. I wondered if you might be able to talk on that because it seems like it still has that same negative reinforcement loop. The benefit is the alleviation of the emotion they don't want to feel, but
Yeah.
it's not so much a physical parasympathetic or sympathetic system problem. It's just uncomfortable emotions and drinking on that. I wondered if you might be able to speak to that.
Yeah. Again, this could get really complicated or not complicated, but the non-complicated answer is that if you're feeling jazzed up, if you're feeling anxious, if you're feeling angry and you drink, the alcohol can help suppress those moods. So it takes away negative moods. Now, the more complicated answer is a lot of it depends on expectations. I think we're going to talk to someone tomorrow about that sort of thing, that many people assume that alcohol drinking is a really good way to reduce stress. And particularly if you're going into like a social function and there's some females that you want to ask out, if you have a couple of drinks in you, you'll have an easier time doing that. Well, the research shows, and this isn't even new research, this is research from, again, 30 years ago, that if someone consumes a beverage and they think it's alcohol, they will say, oh, I feel so much more relaxed. I feel so much more sociable. And they'll go up and approach women and ask them for dates. If they're drinking something that's not alcohol and they believe it's not alcohol, they'll be inhibited. If they drink something that's alcohol and they believe it's alcohol, they won't be inhibited. And if they drink something that's alcohol and they think it's not alcohol, they'll be a little less, uninhibited, but not as much as if you really believe that it's alcohol. And so I think the paper was, it's not what you drink, it's what you think. So for some things, there's a certain expectation of what alcohol does, and it gives people permission to be less inhibited because they feel that they're already intoxicated. So there's some effects that are not even related to the pharmacologic effects of alcohol, but the social context in which people have been drinking. And then what are the effects of, even if you're drinking and you get a endorphin dash dopamine effect, what does that do to mood? Well, if you're feeling kind of lethargic, tired, depressed, getting that takes away a negative state. So normally we would associate that with the positive effects of feeling euphoric and all. But for some people, if they're feeling a little bit sluggish, tired, or whatever, they have a couple of drinks, it does give them some energy. And that's where that would be sort of negative reinforcement drinking. And so there we're even confusing the glutamate GABA system, as we're saying that's the negative reinforcement part, with the endorphin dopamine system and saying that's just to get the high, but that can take away negative feelings too. Then there's a third mechanism I want to talk about, and that is alcohol has sedative effects, but on the brain, it has preferential effects on parts of the brain. And so if you drink alcohol, the first part of the brain that responds, that is influenced by the sedative effects of alcohol, is what we call the prefrontal cortex, or the thinking part of your brain. The limbic brain is not as effective at moderate levels of alcohol. Now, eventually, you can drink enough alcohol that it turns off the limbic brain, the motor brain. You can drink enough that it turns off the whole brain, and you can die. But at moderate levels of drinking, it turns off the thinking part of the brain, the part of the brain that looks at long-term consequences. And so that's why people often act more impulsive with alcohol. There are some people who use, and I did an experiment with college students who like that effect, who like sort of a myopic view of the world. I just want to focus on the here and now and not worry about what's going to happen in the future. And they might be anticipating some terrible event. I have a big exam in a month and I'm worried about it, or, I can't pay my bills. And when they drink, they're just focused on now. They're not worried about the long-term consequences that are out there. And again, that's another example of negative reinforcement, but not even related to the glutamate system. Well, it's related to the glutamate system in terms of you're not drinking to take away withdrawal symptoms, but you're drinking alcohol to get the sedative effect, to take away the worry about things that are not happening now. So when you really talk to someone, you find that there's various sort of subtle reasons why someone might drink. And you have to, as you begin to explore it with them, you can find out what those reinforcing effects are and begin to address it in other ways without using alcohol.
Thank you. Yeah, that was really
Yeah.
helpful because I notice people who tend to, this is the lingering component of TSM, I find for a lot of people. They're not drinking for the enjoyment anymore, but this is the part that continues to go on, that I still drink because I'm just not feeling, if I don't drink, I just sort of dwell in this negative space.
Yeah, that they're anticipating something that's bothering them in their life, and the alcohol gives them a break from that because they can
Yeah.
focus just more on the here and now and not worry about something that could happen in the future. Or alternatively, maybe there's something they feel really guilty about in the past, and that's bothering them, and the alcohol, you don't think about what necessarily happened in the past either. You just focus, it's a myopic view of the world, what's going on right now.
Yeah,
Thank
in
you.
that
Sorry,
same
well, Steve.
vein, in that same vein, and back to like polyvagal theory, there's some belief and understanding that just going to parasympathetic when you're highly activated is probably missing a step. Okay, in other words, that you need to confront in some way that activation energy, okay, and then invoke the parasympathetic. So that if you just go straight from activation to parasympathetic, you miss a step. And here's what I think the implication of that is. So, for example, if a person comes home to drink to get rid of the anxiety and stress of the day, all they're really doing is kicking the can down the road. They're replacing
Mhm.
they're using sedation to resolve that issue rather than to maybe spend a little bit of time thinking, reflecting on that, what caused that anxiety, and then invoking some parasympathetic tools, to help offset that. That's
Yeah,
just something.
and you're right. If you have a very myopic view of the world and there's something that's out there that's bothering you, maybe you need to look at that and deal with that
Yeah,
rather than just focus on the immediate here and now. And because that's something out there will eventually become in here. So,
yeah, yeah. That's the idea. Is that in the idea is that just by seeking relief, we haven't really resolved it. Okay, we got to confront it and,
Deal
factor
with
that.
it.
Let's see if we got here. Okay. Did anybody else have further questions? We got time. I'm gonna say that Dr. V is here
Got
to
one
answer.
more that might be helpful for people. Dr. V, you mentioned that chapter that was available for medical practitioners.
Yes.
Is that publicly available? So if anybody
Yeah.
on this
So look
needs
up to
information,
date. So many doctors will have the up to date, which goes through a variety of medical conditions. There is a chapter in up to date on how to do ambulatory detox. And I know because I wrote it a version, a couple of versions ago. They have somebody else writing it now, but I wrote the version from in the past. If for some reason people can't get a hold of it, I have copies of what I wrote. Just contact me and I'll send the doc a copy of what I wrote. But it's pretty simple. It's not a complicated protocol.
great. Yeah, because I figure if somebody's looking to arm themselves for a discussion with their doctor,
Sure,
holding
we'll
the
send it
reference
to
that
them.
they would use would hold a lot of weight.
I wonder if it's something that we could scan and make available for people.
I think so. We will look into that. I mean, it occurs to me that it should probably be one of our resources that people can go to.
Hmm.
So we'll try to find it. And if I can't find it, I'll pester you for it.
That would
How's
be
that?
fine.
All right. Let's see. Well, a whole bunch of thank yous.
Oh, I appreciate it. Thank you very much. And let me say thank you because I've learned a lot. It's really helped me. So
Well, it's really great to have you. It's always great to have you. And we spend a lot of time talking about a lot of things together. Um, and I try to bring those back to the community as much as possible, but there's just nothing like having you
uh,
uh, to address folks. So, really appreciate your time, really appreciate your dedication. And you're just a very generous person.
thank you. And the community, I think, needs to feel proud of what you guys are accomplishing, that you're bringing information to your doctors and to other people, and it's growing. It's taken off. There's something happening right now.
Yep.
So it's great.
It's exciting times. Great.
It's
All right,
uh,
folks. I'm gonna say one more time. If you got a question, now's the chance to raise it.
if
Let's
you
see.
think of something later, drop it in the chat or whatever, and Steve will let me know if I missed something. So I'm always happy to help out. So
Right. For those of you who can't sleep. Oh, Henry, go ahead. You got something. I see your hands up. I didn't see it before.
Yeah, hi. Better late than never. Hi, Dr.
Well,
V.
I apologize
hi,
because
Henry.
I don't have a big enough screen.
No, I just popped in at the last second. It's been a fascinating hour. Thank you so much. We actually met in October up in Philadelphia area for the Naltrexone Alliance, and that was
That's great.
really wonderful. Yeah, thank you so much. Great to meet you and all the others. I want to appreciate your psycho-biosocial approach
Mhm.
to treatment. I've been through several modalities. And as a host on these meetings, I find it, really instructive to help people come along in a kind of synthetic and synergistic method towards health and well-being. So that's very much appreciated. I have a little side issue, and Steve has probably raised this with you, but as far as your center doing advocacy in the public space, we were talking about putting together a little bit of a public service announcement in the form of an animated cartoon,
Oh,
a 2-minute thing that could be on people's phones and they could show it to their friends in a pub or at the holidays, excuse me, that would explain naltrexone in a 90 second soundbite. And so we're looking for someone who could house that project and help us launch it in a contractual way. And again, Steve was going to bring this up with you, and we're looking for a home for this kind of project. And I thought you might be interested in that.
Sounds
So-
like it's
Yeah.
something right up the Naltrexone Alliance alley.
Yeah, I'd say it probably got lost in the shuffle over the last week. I sent an email to you with the proposal, and basically what Henry's looking for at this point is when he says an entity or a contracting party, simply somebody that has a nonprofit that can sign an agreement.
Mhm.
There's no financial commitment or anything of that nature. It's just to house it.
Sure.
And so I sent that off to you. I told Henry I thought that probably was going to be quite doable. Raising the money to do it, that's a challenge that Henry's taken on, and he's got some pretty good sources working on that. And
Well, we'll hold the bake sale, and we will make the money.
That's great. That's
Yeah.
great.
We would like an institution to sign the contract
Sure.
and just be a base for our efforts.
Yeah.
so,
That sounds like something the Alliance is all about, and that's part of the Institute of Addiction Medicine, and that's what we do.
yeah, that's I kind of figured that we run the Naltrexone Alliance as a quote unquote project underneath the institute, and so this would just be a similar kind of thing.
Well, that's great.
It's-
This is all I need to know for now. Thank you so much for answering that question. And Steve will push this forward.
Yep.
And yeah,
So I've been having
Great
fun
evening.
with using AI to create these little 90-second videos. So let me know what you're up to. And
oh, okay. Well, we need to go with the Chinese AI because the American AI has
yes, not as
seriously
smart.
tanked this week.
Oh, so I just signed up for something where it will clone my voice.
Well, I was talking about human creators, and I think you would probably embrace the humanistic aspect of.
Yes, well, what I
Project
find working
exploration.
with AI is it works much better if you work collaboratively with it. If you just send it out to do something, it comes back with crap. But it's a good tool to work together with you.
Yeah,
So
no, we want to employ creative geniuses who
there you go.
show a lot of love and compassion to the
There you
project.
go.
Okay, enough for me. Thanks so much. Wonderful to see you again.
Great, thanks.
See you soon.
Okay. Well, again, thank you very much on behalf of our whole community.
Well, keep up the good work. This is great.
Pardon me?
And as I tell you, this Discord community is growing faster than like any other community. It's what do you have, like 1,000 people now?
Yep. Yep.
It's how long did it take to double?
Well, I don't know. Somebody has a growth curve, but we just all had to put in our guesses as to where we were going to be at the end of next year. And
2,000.
well, there was definitely some 2000s there. I'm trying to remember. My number was something like 1952, I think was my number, but they ranged pretty well between 1,000, where we're at now, 1,000 and, with good growth. So I'd say probably most of the estimates were between 14 and 2000.
Oh my goodness. We can celebrate. We broke 1,000.
Oh, did we?
1,011 right now.
All right.
Wow. Congratulations.
There you go.
Yeah,
Congratulations.
I bid 2025, and I think if Dr. V comes in and steps us up a pumpkin spice latte from Starbucks, we might get up to 2,000 before too long.
Yeah. Well, I mean, we must have added 11 real fast there because we were at like 995 and we must have added 20 people just real fast. So that's
That's
great.
what I mean. That's you blink and another 10 people join. It's incredible.
All
Okay,
right.
998. Okay, we got some bots in there.
Oh, well.
That's great. Well, let's get to 1,000 so we can have a big celebration.
There you go. We're right there. All right. Thanks, everybody.
Yes, thank
Take
you.
care.
Thank you, Stephen. Thank you so much, Dr. V. We love you.
Oh,
Thank
thank
you
you.
so
Thank
much
you.
for being here. You just don't know how much you mean to our community.
Oh, thank you.
All right. And
Thank
thank you, Steve, as always.
Sure. Okay.
Bye.
Good night, everybody.
Yeah, thanks,
Bye-bye.
Dr. V.
Yep. Thanks, Steve, Dr. V. Have a good night.
Take care.
I can stop recording.